Thanks for inviting me here. I'm really grateful to the St Luke's team for holding this conference, which I think is a fantastic idea, and to be asked to come and talk about this piece of work, which is very important to me. It's a piece of work which I had a small part in. I was asked to chair the expert reference group. There were a lot of other people, as you can imagine, from NHS England and PHE, and also those members of the reference group and the pilots involved. So I'm presenting on behalf of all of them. What I'm going to tell you about is what the project set out to do, what the projects were aiming to do, and some of the evaluation. And then at the end, some of the bits that perhaps we didn't get to do, and what the aspirations would be going forwards. I think the fact that so many people are here at a conference for a day about outcomes just reinforces how much all of us believe that outcomes are important. And what was identified at the beginning of this project was the importance of outcomes for patients and for the quality of care for our patients. So in specialist palliative care, outcomes can help us improve care for individual patients. They may be able to better support patient choice. They can also have some other effects, which I think you've seen already from Sam's presentation this morning about streamlining team working. And the ambition when we started this project was actually that we would be able to use data across teams to compare services and benchmark and to drive up quality in that way. And then to think on a bigger scale in terms of local and national audits and quality improvement projects. Other objectives, we were working with the then tariffs, now currencies, to join those two pieces of work up, to also collect the information that would be required for the future currencies for palliative care. And also thinking about what this information would give us in terms of what's happening in specialist palliative care nationally, which we don't currently have. We have the minimum data set, which provides us activity data, but it's not per patient, it's not individual level data. And some other ambitions about effectiveness, cost effectiveness, and informing research. So it was quite an ambitious project with quite a lot of things on the wish list. How did we devise and develop the data set? We basically looked at what was out there in terms of evidence, so validated tools for collecting information about patients. We wanted to collect demographic data as well. We wanted to collect data about complexity and included the data that the palliative care currencies was using. We also wanted to be able to track patient movement, so we did something quite ambitious, which was to look at dividing care into spells, so whether that be in the community, in daycare or in hospitals. And that proved a little bit challenging, so I'll tell you later. We looked at international experience, and Fliss is going to tell you more about the Australian experience after this. Before the pilot started, there was a national consultation with providers. Some of you may remember that in the dim and distant past. There was also a national consultation with the public, both end-of-life care related and the general public. We did an IT capacity assessment of hospices, which gave us some interesting results. And then the data set itself had an iterative development. So as the pilots went on, those pilot sites would come back and say, this isn't working, you need to redesign this. We'd check that against the other pilot sites, we'd take it back to the expert reference group, and we'd change it. So it was something that developed through the time of the pilots. And the expert reference group was just one cog in that bigger wheel, where we collected providers and academics and lay members, members of NHS England and PHE, to collate the information to drive forward the projects with the steering group. So the pilots themselves were about assessing the feasibility of this data set that we had come up with. And the evaluation that we planned was multi-pronged, really. We looked at the contents of the data set. As I said, we had that as a kind of iterative process as we went on, with the pilots coming back and saying, this is working well, this really isn't. We did an initial analysis of IT capability of local and national suppliers. So we looked at what specialist palliative care providers were able to collect in terms of IT before the pilot. We also went to IT software providers and said, what would you be prepared to do? How can we engage with you? Something that I think in some of our groups this morning we were talking about the importance of. In the evaluation, we looked at staff readiness. We looked at timescales through the pilot to reach staff readiness. We looked at costs. Somebody was asking about costs, so I can tell you in the case of these pilots what it cost, what they told us it cost. And then at the end of the pilots, we interviewed all of the pilot sites to get some qualitative data to improve the richness of the information we had about their experience of taking part in this data set collection, what went well, what didn't go so well, and what they would suggest to future implementers. We had also intended in our evaluation to look at a scope and function of the national clinical data set, which we didn't get round to doing. And we also meant to set up a legal gateway for data sharing. The situation in the NHS is that there are some processes whereby you can collect and share data, but in order to make the process robust, we really felt we had to do what's called a formal information governance, information standard process, and that was one of the purposes of the pilots. For reasons which I'll explain later, because we didn't then go on to have a nationally funded process for collecting data, we didn't go through that legal gateway. So that's one of the parts of the pilot that weren't completed. So evaluation. What I'm going to show you is some information about what pilots told us and averages across the 10 pilot sites that were that took part in this process from the beginning to the end. What we asked pilots to do for each part of the process was to set a target for completion, and then we looked at the average time that it took. Some of these amounts of time are overlapping, so they're not from the beginning to the end. But in terms of how long we thought it would take for pilots to submit data, the average that they took was about 6 months. However, that's only 8 of the 10 pilots. 2 pilots through the whole process, and it lasted about a year in total. By the end of the process, 2 pilots were still unable to submit data to the national team. They were collecting it locally, but because of issues with consenting, the consent process, the information governance around consent, they were unable to submit that data, to share that data with the national team. We had a data sharing agreement that we offered to sites, and that seemed to be acceptable, but there were local governance processes associated with that sites wanted to take up, for instance, patient information leaflets, and how to train staff in consenting patients. The reason we had to consent patients is, as you remember I said, you have to go through a process to get permission to collect and share data without consent. So for the purposes of these pilots, we could only share data where patients had specifically consented for their data to be shared with the national team. And data sharing and consent took time. And you can see that for the consent process, one organisation really never got through that whole process. It's down as greater than 11 months for the time that they took. In terms of implementation, system readiness, so that's largely IT system readiness, was one of the challenges in this project. And I think, again, it was something that came out of the groups this morning as a challenge for implementation for outcome measurement. Those units where there were existing IT processes or where they were already undergoing an IT development process and could tack this on to those development processes found it a lot easier. but it took time. Staff readiness was partly about training, but I think a lot of that is about engagement of clinical staff as well, and not specifically about training. And I don't think we should underestimate the importance of engaging with those clinicians that are going to be handing out and collecting back the IPOS data, or in measuring staff outcome data. Data collection, we looked at how long it took for units to implement the currency data and the outcome data, and you can see 3 to 4 months for each of those, but actually less problems associated with collecting that data than with the IT or with staff readiness. Costs. So somebody was asking about costs a little while ago. The answer is that we have some information from the 10 pilots that took part, but it is so widely variable that it is very difficult to tell you, for your organisation, how much it's going to cost. We asked the pilots to divide their costs into how much it costs to configure the systems, so largely IT, and how much it costs to implement the data set, including staff costs. And what you can see is that both of those figures start very low and end up quite high. Those units where the amount started off very low were either units where they already, for instance, had outcomes tools within their IT system, or where an organisation was making a development in IT and just added this on to the IT development they were already planning to do and had already paid for. So they didn't identify any separate costs for this project. Similarly, with implementation and staffing, those units where they were experienced with outcome measures and were using them already clearly had less need for engagement, training of staff and implementation than those where they were starting from the beginning, where they'd had no experience of outcomes, no experience of using IPOS and similar measures, and really were having to start from the beginning in terms of engagement and training. So we come to, I think, two of the most important messages for the pilot, which is that IT system readiness is clearly very important, or planning for IT system readiness for implementation of outcomes, and certainly for this project in terms of the national data set. And if your unit has got experience of using outcomes or currency measures, then you've got a bit of a head start. If you haven't, you need to build that into your planning process. So we interviewed all the pilots and asked them what they thought had really helped. And I'm presenting this to you in the hope that it will help you as well. We asked all the pilots, what changes have you had to make as part of taking part in this national project and the pilots? And one of the things that lots of them came up with was, well, we've had to change our IT system. What they said about changes to IT system obviously varied massively. So some of them had to make minor tweaks, and others had to buy in a new IT system or create one in-house to be able to collect all the information from the national data set. There were changes in clinical recording practices, which again went from major changes in terms of what staff were being asked to do and the challenges associated with that. And you can see this quote, changes include both changes in clinical practice on the ward and in various teams, trying to measure patients' needs using IPOS and Karnofsky. So they hadn't used those tools before, and it was really about trying to initiate and embed those in clinical teams from scratch. Another major change was the consent process. And as I said, this was something we wanted to go through in order ultimately to be able to have a decision from on high that we could collect and share our data from our palliative care patients without consent. We didn't in the end go through with that process, but it was challenging. Massive culture changes, in consenting patients to collect data. What went well? There were some mixed responses, but the majority of our pilots found that the outcome measure tools, including the currency measures, performance status and phase, did actually give them some benefits in terms of being able to talk about patients in a way that described them and where they knew they were using shared language. And this is something that came out quite a lot, that it was a way of almost a shorthand, almost a clinical shorthand for describing how a patient was. So by describing patients in terms of their performance status, so AKPS Karnofsky performance status from Australia, hence the A, phase and IPOS scores, you very instantly get a picture of what they're like. Several pilots described improved working practice, so Luke's wasn't alone in that. It's allowed us to review the MDT, to review the way in which we work and the way in which we assess our patients. So it's actually refined working practices as well as care for individual patients. And improved patient care, some units, we had a couple of direct quotes saying they could actually see how collecting data on individual patients affected patients, family and carers. What helped or hindered implementation? The thing that came out most strongly from these 10 pilots, and remember it is only 10 units, but the thing that the consistent message that came out from those 10 pilots is that you need support from clinical leaders for this to succeed. Even in those organisations where IT systems were not already in place that could collect the data set, it seemed that good support from clinical leaders was able to overcome that barrier. Conversely, although IT infrastructure and support was mentioned as something that was really, really important, in at least one unit where that was in place, but there was an absence of really involved senior leadership, they were not able to finish the data collection. So our conclusion about that, from the limited data we have, is that the IT system readiness on its own is not enough. You need really, really strong senior clinical support for this to succeed. And I think that's probably relevant for all outcome implementation. Those units that were lucky enough to already be doing IPOS said that was really useful for us. But obviously that's not something that you can particularly learn from. It was just lucky for them. Challenges of implementation. This consent issue was a huge bugbear for our providers. There were issues about how to go about asking patients for consent when we are just not used to asking patients for consent in our clinical practice to collect information about how they are. Some units, as I said, felt that they had to do a patient information leaflet. That took them time because we didn't provide that. There was a huge culture change in asking all clinical staff to say to patients, before you collected data, I want to share this with a national team, is that okay? Some staff were incredibly resistant to that, and actually that became quite a slowing measure for some of the pilot sites. And there was a burden. There was a burden for staff in asking for consent, and there was a perceived burden on patients too. Interestingly, we know from research in specialist palliative care that a very high proportion of our patients are unable to consent for instance, research projects because they're too sick. So we had expected that when we asked units how many of your patients were unable to consent and therefore you haven't given us their data, that it would be of the same order, maybe 50%. What we came up with from the pilots was only 13% of the patients in these pilots were said to be unable to consent. And we don't know why that is, but we suspect there might have been a bit of a selection bias. What we hadn't expected was that 10% of patients would refuse consent for data sharing. And that's quite interesting, I think. And it's not something that we've seen from similar projects in other areas in healthcare. We talked about IT being a challenge. The timescale was a challenge for some. We were ambitious. We aimed to get from the beginning to the end in terms of submission in a year. We actually extended it a little bit, but even then, as I said, 2 units were unable to submit data, where probably if we'd allowed a bit more time, maybe 18 months to 2 years, they would have at that point got through the issues that they were struggling with and been able to extract and submit data. So I think that's maybe another lesson from this project, that it takes longer than you think it's going to take. Staff engagement was mentioned by several pilots as a real issue. And I think that's where the senior clinical involvement and leadership comes in order to get all the staff at the front end really engaged and owning this, where in some circumstances it requires quite a lot of extra effort. You do need that push from above. And again, there's a quote from just one of the pilots. It was a challenge getting staff to think and act in a different way. Fliss and I have talked at length about this hump or dip, depending which way you look at it, between when you start to implement and when you start to see the benefits of implementation. And I think the bits that are involved in that dip, where actually it feels more burdensome than beneficial to the staff, it requires some thinking about at an organisational level. And I think that's the bit where you need lots of enthusiasm and lots of maybe early messaging about successes to keep going through that dip until you can actually see how it's working for you as an organisation and for your staff to see how it's working for the patients. Other challenges. I mentioned that we tried to design a data set that collected information about where patients were, where they were being looked after, as well as collecting data about outcomes and about the currencies. And as part of this, we went through quite a complicated process of deciding that people they'd have to be in one place, as it were, at a time and receiving care mostly from one team at a time. And of course, that's not how things happen in real life. It was a slightly artificial mechanism we put on the data in order to make it easier to capture and analyse. And so not surprisingly, people found that quite challenging. This person's in daycare, but they're also having community care and they're also having something else care. Where do we record that? Care reviews on care we added into the initial data set. Collecting information about carers was a challenge for some of the pilots altogether, because I think we'd introduced the consent issue. I think we all are used to collecting information about carers, how they're doing, what the impact is on them. But I think because we'd asked our staff to consent patients for sharing of data, there was this feeling that somehow you had to consent carers too, and maybe you had to collect their data in a different place, and what did that mean organisationally? And then this particular measure, carers' views on care, was not popular with the pilots. So we actually dropped it from the final data set. We have a data set. We have a national data set. There is going to be a publication soon describing it in its final form. It has been tested, but it hasn't been validated. And I think that's quite important to say, especially with Fliss coming on after me. So actually, in an ideal world, we would do some more work on quite a big scale to validate this tool. That's not something where we currently have any plans, although Fliss may tell you differently. Because the national data set is slightly different to OAK. It doesn't contain all the same measures, and it contains some extra The main concern I think we had as an expert reference group about the use of the national data set was because it measures activity as well as measuring outcomes and currency, it could be used as a sole way for external bodies to look at what we were doing as organisations. But it doesn't measure any of the indirect care that we all provide in terms of advice and support and education. And so I think our concern was that that needed to be explicit, which it is in the report, to give a very strong message to commissioners, amongst others, that if you wanted to use this sort of data set to commission specialist palliative care services, there would need to be other things that you commissioned as well, which are outside what this measures. The biggest disappointment for all of us was that this process was working towards a national clinical data set that would be collected and analysed nationally with information fed back out to providers, which would benchmark providers against each other and allow for us all to drive forward quality in our own localities in the same way as they've managed to do in Australia, which Felicia's going to tell you about next. And we were unable to secure funding to do that. As a result of the fact that this was not then going to be taken forward as a nationally collected clinical data set, we didn't go forward with the information standard which would allow us not to need consent. We are hopeful, and Barry has suggested a way that in the future this data set may be embedded into other ways of collecting it nationally. So we haven't given up hope that this could be a nationally collected tool, but currently there is no funding to do so. And that was obviously a massive disappointment to the pilot sites, the expert reference group, everyone involved in the project. But I think it's important not to lose sight of the fact that the work that was done, largely by the pilot sites, not by me, has produced this data set which we believe is fit for purpose. We asked the pilots what they thought about the opportunity that might be available in the future for this to be a national data collection and what they thought the role of that would be. And there was overwhelming support in the pilots for that to happen. So it's not just something that I think there's an ambition from externally, it's also individual pilots could see the value in being able to benchmark their service with similar organisations and the power of that in terms of improving patient outcomes. If we decide to do that, the consent issue then comes back into focus, because at the moment we do not have permission to share patient data for this purpose at a national level in a non-anonymised way where we could then track patients. If we were doing it in an anonymised way, we wouldn't need consent. The other aspiration, I think, is, as I said, that this data set as it stands has validated tools within it, but is not as a whole validated. And in order to make sure that it measures what we think it measures, we would really need to go through that very cumbersome process of validating the whole tool. So I hope that's an understandable run through of what the Palliative Care Dataset project was all about, with some of the results, some of the challenges, and some of the things that are kind of left undone, but in my slightly optimistic way remain aspirations for the future. Thanks very much.
I've got just a couple of things that came up for me, Sarah. Just really talking about, we've talked a lot about the data set and how we implemented and different pilot sites went about it. And you touched on 2 points that I thought were very key for us in our growth around this. Was partly about leadership. Yeah. And do you have a view, not necessarily a Public Health England view, but do you have a view about if someone was starting this process from the beginning, what do you think the sort of leadership from the experiences that you've seen is required to help people take things forward?
short of saying go to St Luke's.
Oh, that's very kind of you to say that.
Well, I mean, I can't imagine a site that's really taken it and run with it as enthusiastically and wholeheartedly, not denying the challenges. I mean, I think St Luke's were one of the more vociferous pilots that came back and told us what really wasn't working. But I think there is something, I mean, the strongest message we got from pilots was about the clinical leadership. And I personally think that because it is going to be our clinical colleagues who are going to be implementing these outcomes, that they are the ones that you need to win heart and minds of, and they need to understand really the rationale behind it. You know, why is this change necessary? Why are you asking me to do some more work? Why are you asking me to ask patients to do a bit more work, which is sometimes how it can feel. And I think one of the ways of doing that is obviously the engagement and the initial discussions, but I think any sort of early feedback you can give to teams about what they're measuring and what it shows. So rather than just getting people to measure it, planning early on in the process to have some sort of feedback about what is being measured and on a patient level, how those patients are changing and how the data can show those patients are changing. Maybe how your working practices are changing. I think all of that is incredibly helpful, and what that suggests to me is it's not just clinical leadership, but it's also organisational leadership. I think it requires both, really.
And just the last question for me really was about the issue around IT readiness, and that's obviously a massive issue for all of the pilot sites, and we all work very hard to find different ways to get around that. Those of us that had flexibility within our own systems perhaps had an easier ride than those who were needing the IT providers to make those kind of changes. I mean, Fliss at the start of the day talked about potentially talking about how we engage and keep that dialogue with IT providers. How did it work in the Public Health England pilots? What do you think is the future for all of us if IT readiness is the limiting factor? How do you think we move forward as a sector to tackle that?
I don't really have an answer to that. I think one of the things that we talked about in our breakaway group this morning was local engagement, and I think one of the things that became clear from the people that had been engaged in IT sharing locally was that they had an opportunity then to go to their local providers, who it's very easy to see as competitors, but in some ways we do need to work together, and that they had therefore more influence as a group of providers who were already recognised by local commissioners, I think, to say this is what we need to providers, I think to IT software providers. I think as individual organisations it's very difficult, isn't it, to influence that change. For the Palliative Care Clinical Dataset project, we did go to IT software providers right at the beginning and did a piece of work with them where they were all clearly very enthusiastic about developing systems which would collect the whole of the clinical data set. So I think at national level there's a possibility of doing some work, but I don't quite know at the moment who would be driving that. Barry's put his hand up. Barry's going to sort it all out for us. If there is a national data set that is part of a collection that exists elsewhere, then it becomes something I think that will be very easy to sell to IT software providers. Because
it's more fundamental than that. Once it becomes a nationally mandated data set, the Sky issue a standards bulletin which gives 6 months to systems suppliers to actually change their systems so they can collect the data that's required by the national data set. So all the issues about getting your suppliers to do it go away at the same time as all the issues around consent go away, because the NHS has directed NHS Digital to collect the data. So the consent issue is dealt with at the same time as the suppliers are told they have to modify their systems in order to collect the data. Now, that's how it looks in theory. In practice, sometimes it takes a bit more cajoling with the system suppliers, but it does tend to happen.
Thanks, Sarah. I was going to ask a question which is not designed to be clever at all. It's a genuine sort of mystification on my part. On your first slide, you talked about outcomes measurement being important to allow choice. And I think in the hospice that I work in now, we've got it, in some ways it has helped us be much more clearer about need, and it's reduced the fluffiness that enabled us to do as much around choice as we did. So can you say something about how you were able to put that under there as a sub-point?
So when the data set was initially developed, it included a data item about preference, which was another very contentious item, and was actually changed. So I think the initial wording was something like preferences of care, which we all agreed as we went along was much too woolly, and became, I think, PPD. So the PPD is still in the data set. There are other choices that are important to patients, and what I would say is measuring accurately outcomes gives people more choices if you use that information to direct their care. So I suppose it's two-pronged really. It's choice in the classical and somewhat limited way that we've all come to accept is a reality, but we don't like it very much, in that preferred place of death is a way of looking at outcomes that has been used in the past but we want to try and get away from, which I think is what you're saying. But also that actually if we're more accurately collecting information about what's really important to patients, then there is a choice issue in that.
Thank you very much. And thank you, Sarah, for the presentation.